is systematic reviews. Each presenter will have about 12 minutes and then we'll have some time for questions after each presentation. So we'll jump right in. First up, we have Mr. David Nguyen. He's going to be talking about missing data in individual participant data and analysis.
Do I just talk in this mic?
Yeah, well, you can use the mic if you want to walk around.
Cool, thank you. Hello, and thank you for the introduction, Kylie. So today I'll be discussing what approaches are being used to deal with missing data in individual participant data meta-analyses of randomized trials. I'd like to begin by acknowledging the traditional owners of the land on which we meet, the Gadigal people of the Eora Nation. So first, I'd like to begin by explaining what is an IPD, or an individual participant data meta-analysis. So an IPD meta-analysis involves the combination of de-identified participant data from multiple studies in order to address a single research question. And doing so provides us with an overall summary of the current knowledge available so far. With the IPD, we're able to conduct more flexible and powerful analyses compared to what traditional meta-analysis can do alone using summary data. But more importantly, IPD meta-analysis allows for consistent handling of missing data within each study, and this will be the focus of my presentation. But why is missing data a problem in IPD meta-analyses? Well, first of all, missing data leads to a loss in statistical power, and because when we have an incomplete data set, this leads to reduced precision in our analyses, and so we have a higher uncertainty in our results. Secondly, we may get potential bias when we make the wrong assumption about the patterns of missing data. So when we have missing data, we need to consider, was missing data completely at random, or was there some underlying factor that led to a selective subgroup of the original study sample? An example of this would be we have sicker participants in our IPD, which may be more likely to be lost to follow-up, and therefore they are more likely to have missing data. So whenever we make any analysis, we have to make an assumption about the pattern of missing data. And if we make the wrong assumption, then this could lead to biased estimates in our results. And thirdly, potential bias may also occur when the missing data approach is inappropriate, regardless about the pattern of missing data. So ideally, the missing data approach should be able to handle missing data in outcomes such as mortality or morbidity, and covariate data such as age, sex, and other baseline characteristics that are used to define our subgroup populations. And the missing data approach should also be able to handle sporadically and systematically missing data, or in other words, when data is partially or completely missing within a trial. So what must we do to deal with missing data in IPD meta-analyses? So to improve statistical power, we should try and minimize the amount of missing data that we have in our IPD. And one of the first things that we should try and do is to contact the trial investigators for additional information. And in my experience, missing data can simply be due to miscommunication or oversight when requesting IPD from trials. Or we can try and use an imputation approach to replace the missing values. Secondly, we should try and think carefully about the right assumption about the pattern of missing data. And whatever assumption that we choose, we should try and perform sensitivity analyses around that assumption to check the results remain the same. And thirdly, we should try and choose a suitable approach for the type and extent of the missing data that we have in our IPD. And here are the common approaches that are used to deal with missing data in general. So a simple approach would be to use a complete case analysis where we exclude participants with any missing data. But this approach has been widely criticized for ignoring the patterns of missing data. So we should only really be using complete case analysis if the data is missing completely at random, or when we have a really small percentage of missing data in our total IPD. A second approach would be to use single imputation, where we replace missing values with a single number, such as the mean. But this approach is generally inappropriate for dealing with missing outcome data because it doesn't take into account the uncertainty of the imputed values. A third approach would be to use multiple imputation, where we impute each missing value on at least 2 occasions. And this approach is generally recommended for imputing significant amounts of missing outcome data. And in any case, there are many missing methods available to deal with missing data, but currently it is unclear about what current practices are being used to deal with missing data in IPD meta-analyses. And this leads us to the motivation of our research project. So our first objective was to first identify what approaches are currently being used in IPD meta-analyses of randomized trials, specifically in how they address missing data in both outcome and covariate data, and how they address both systematically and sporadically missing data. Our second objective was to evaluate the assumptions being made about the patterns of missing data in each approach, and thirdly, to provide some recommendations for practice. So for the method, we've conducted a methodological review of recent individual participant data meta-analyses, and this is the QR code that links to the protocol on the Open Science Framework. For the eligibility criteria, we've looked into IPD meta-analyses that had recruited at least 2 randomized trials that were part of a systematic review, and these had to be published between 2020 and 2023. We've identified 235 eligible papers, and from that, we've randomly selected 100 of those papers. And then we developed a data extraction form to extract in duplicate information about the study characteristics, general information of missing data, and other important details about how missing data was dealt with in the IPD meta-analysis. And this is some of the characteristics of the 100 papers in our sample. So we stratified the random sampling so that we collected 25 papers from 2020 to 2023. On average, the number of trials with available IPD was 7, and the number of participants with available IPD was just over 2,000. Cancer was the most prominent medical field in our sample, followed by cardiovascular, mental health, endocrine and nutrition, and pregnancy and childbirth papers. And then when we're collecting general information about missing data, one of the first things that we tried to collect was whether the IPD meta-analysis reported anything about missing data in any capacity, meaning did they report anything about missing values, or did they provide any information about how missing data was dealt with? And surprisingly, there's only 66% of papers that reported missingness. So we're already seeing a big gap in how missing data is being reported in IPD meta-analyses. In the 34 papers that report nothing, it is a bit concerning that we are unable to evaluate if the missing data approach was appropriate or not. And in any case, because 66 papers had reported something about missing data, or all of the following results in this presentation will be based on the 66 papers. For example, we've collected whether there was any attempt to recover missing data from the trial investigators. Only 9 reported yes out of the 66, but this is probably a reporting issue rather than something that wasn't being done. And next, we looked into whether there was any missing values in outcome data. So most papers had reported having missing values in outcome data, 83%, but there was also a portion, 17%, where it wasn't really clear on this. And then for covariate data, around half of these papers had reported having missing values in covariate data, but a bigger proportion of papers did not report the amount of missingness in their covariate data, which shows that there is some room for improvement in how we're reporting missingness in covariates. Next, we looked into whether data was sporadically or systematically missing. And here at the bottom, we can see that there is a big proportion that don't actually report the type of missingness, especially for covariate data. But for the papers that did report something, outcome data tended to be only sporadically missing, whereas for covariate data, it kind of was equal between either sporadically missing or both sporadically and systematically missing. Next, we looked into what assumptions were made about the pattern of missing data. And we can really see here that the majority of papers don't actually make a discussion about the pattern of missing data. So as I said previously, any analysis that we make must make an assumption about the pattern of missing data. And if we don't take that into account and we make the wrong assumption, then that could lead to biased estimates in our meta-analysis. So here we can see that there is a lot of improvement in how we're reporting and evaluating the patterns of missing data in IPD meta-analyses. So the next method the next step was looking into the primary method used to deal with missing data. And then here we can see that there's a wide range of approaches used to deal with missing data in both outcomes and covariates. But by far, complete case analysis is the most prolific approach. And then here, I've plotted the proportion of missingness in the primary outcome for each analysis type, noting that only 44 papers had enough information to be included in this figure. So here, the proportion of missingness in the primary outcome ranged from 0 to 40%. And of the complete case papers, we can see that there is a significant proportion that had a high number of the missingness in the primary outcome. So these papers are quite at risk of selection bias. So it would be interesting to see whether if they did a sensitivity analysis to see how robust the primary results were. And this is what I've done here in the next slide. So we can see in the number of red points that most of these IPD meta-analyses don't report a sensitivity analysis, especially for those that have done a complete case analysis. So it would be interesting to see how much results would change if in these complete case papers, if we'd done a different approach, such as a multiple imputation. But unfortunately, these papers did not report this. So to summarize, 34% of IPD meta-analyses in our sample don't report missing data at all, which highlights a lack of transparency in how missing data is being dealt with. Assumptions about the patterns of missing data were rarely provided, which makes it difficult to evaluate whether the missing data method was appropriate or not. The most common method data approach in IPD meta-analyses is the complete case approach. And as we saw previously, that the complete case analysis was still being done even when there was a significant proportion of missing data. And lastly, there's a reporting of missing data methods still needs a lot of improvement. There were a lot of key details that were missing during the data extraction, even when we were checking protocols and statistical analysis plans. And the methods for missing covariate data were particularly underreported. So the next steps is to try and improve how IPD meta-analyses are reporting and practicing how to deal with missing data in general. So there is already some guidance on how to handle missing data in IPD meta-analyses, but there clearly needs to be some further guidance developed. So here we plan to publish our findings from this presentation and provide further recommendations for practice. Next, we want to aim to promote transparent and clear reporting of missing data methods using IPD meta-analyses. And this could be done by, for example, proposing some additional reporting items in an update to the Prisma IPD statement, specifically to try and collect whether how much extent of the missing data that they had and what missing data approach that they used. And in this presentation, it wasn't really made clear about how results would change based on the missing data approach and the pattern of missing data. So in the next step, we want to try and conduct a simulation study to demonstrate how different data methods can change IPD meta-analysis results. And this will be detailed in a protocol update or statistical analysis plan. And I'd like to acknowledge my team here at the NHMRC Clinical Trials Centre and at the University College of London and University of Rostock. And thank you for listening.
Well done. Thanks, David, for fascinating talk. We have some roving mics. If there's any questions, please raise your hand. Oh, there's one up back here.
Hello. I have a general question about missing data that has been nagging me for a while. So it's about data imputation. So if you have missing data, you can use imputation to basically fill up the empty spots in a data set, right? How is that different from basically fabricating data? Because you're making something that wasn't there and you're just putting their stuff there that okay, there's a model behind it, I understand that, but still it's making something from nothing. And a follow-up question is, doesn't it artificially decrease the variance in your data because you're basing these new values on values that you already know? So the new values are in line with what you already have. So doesn't that artificially decrease the variation in the data?
Okay, thank you for your question. So the first part was to look at the missing data. Oh, sorry, could you repeat the first one?
Yeah, is it basically what's the difference between data imputation? Why is that a good thing? And data fabrication is a bad thing.
Yeah, so imputation, it can be really useful to impute the missing values to try and simulate the pattern of missing data. So if we try and fabricate the data by just putting in random points, then this could easily lead to a biased estimate in our analysis. So ideally, we want to try and use some sort of prediction modeling, like in multiple imputation, to try and model exactly how the missingness came to be. So using a proper multiple imputation approach should be helpful to get a more reliable estimate in our meta-analysis results. Yeah.
An online question.
Oh, there's an online.
Oh, yeah.
So this is from Akihiko Ozaki. I may have missed this during your talk, but in your study, how do you distinguish between sporadic and systematic data that's missing?
Okay, so we looked into the we read through the papers to check how much missingness that they had, and looked into, well, we defined sporadically missing data as having partially missing data. So for those papers, we determined that if there was partially missing data, then that would be sporadic. And if there was any completely missing data, then that would be systematically missing.
One more question.
Hi, thanks for the presentation. I may be accused of being self-interested in asking this, but did you look in your 100 papers whether there was a statistician reported on the authorship team and whether that had any relationship to how they dealt with missing data?
That's a good point, actually. We didn't actually collect whether a statistician was part of reporting the missingness in these papers. So, but it is really good to have a statistician on board to develop the methods for imputing or using a multiple imputation approach to try and fix up the missing data values in the IPD.
Right. Thanks so much, David. I realised as well, I forgot to introduce myself before. So I'm Kylie Hunter from the University of Sydney, also AIMOS board member and on the conference organising committee. Really great to see everyone here, full house. So next up, we have Matthew Page talking about unified Prisma stakes.
All right, you can hear me with this?
Yeah.
Yep, cool. All right, so I'm going to talk about this project we've been working on for a while about the unified Prisma statement. So I just want to acknowledge funding for this project from an NHMRC Ideas Grant and to acknowledge my collaborators Joe McKenzie, Dan Hamilton, Sue Brennan, and David Mower. So for those of you who don't know, the Prisma statement is a reporting guideline that primarily provides guidance for how to report a systematic review that evaluates the effects of interventions. And Prisma is complemented by various extensions which are meant to provide guidance for different types or aspects of reviews. And so how have they all come about? Essentially, Prisma was initially published in 2009, led by David Mower and colleagues, and then updated by myself and colleagues in 2021. But in between that period, several extensions came out in the mid-2010s, focusing on different types of outcomes or methods that might be used in a systematic review. There was a bit of a mad flurry just before Prisma 2020 came out, with a few more being published, focusing on particular types of interventions. And then since Prisma 2020 has come out, there's been a couple more extensions that are extending the new Prisma. So what is the review author to do with all this guidance? So looking at this particular review on the effects of tuberculosis preventive treatments, we can see in the title alone that it's focusing on both efficacy of the interventions as well as the harms or safety. It includes individual patient data, and the authors have done a network meta-analysis. So the only guidance we included in Prisma 2020 was that we recommend authors to report their review in accordance with Prisma 2020, the main guideline, along with the guidance specific to the extension. We should have said extensions because in some cases like this, multiple of them apply. So for this review, the authors essentially would need to consult the main Prisma 2020 statement, the extension for harms, the extension for network meta-analyses, and the extension for reviews of IPD. What do each of these look like? Well, Prisma 2020 includes the main list of reporting recommendations that we'd updated in 2020. If you look at Prisma harms, you'll see on the left-hand side, there's recommendations from the original 2009 statement, as well as some minimum extension items and some desirable extension items. So it's a bit different in structure to the Prisma 2020. If you then look at Prisma NMA for network meta-analyses, this again, it updates the original Prisma 2009 statement, but includes some changes listed in italics that provide NMA-specific guidance. And then finally, if you were looking at the IPD statement, again, it essentially was an update of the original Prisma statement, so it's not really aligned with our current update, and includes some IPD-specific items, but none of these are italicized. So the authors of this review essentially would need to comb through 120 pages of guidance to get fully across all the recommendations for their particular review. There's also lots of overlapping guidance across these 4 documents. But more worrying is that there's the potential for inconsistent interpretation because there's important differences in the wording of items that authors would need to reconcile. And this is essentially because these guidelines have been developed by different teams at different times and have had autonomy over what types of recommendations they have included in the guideline. So to help users deal with this, we've decided to create what we call the unified Prisma statement to essentially harmonize the guidance across the current main guideline, Prisma 2020, with the extensions for systematic reviews of interventions. So what we did, we included in this project all Prisma guidelines that relate to systematic reviews of the effects of interventions and excluded things like Prisma for scoping reviews or Prisma for diagnostic studies. We included some other guidelines that are explicitly aligned with Prisma. They had to be published up to the middle of 2023. And then what we did was we went through all the guideline documentation for all the extensions we included, and one author extracted all the reporting recommendations that appear in these documents and classified them either as being an item, so thus providing a synopsis of what to report, which typically appears in the checklist, or an element, which is a bit more of a granular recommendation that typically would appear in an explanation and elaboration document for that guideline. And so as an example here is the Prisma equity statement, which the blue text up the top is what appears in the checklist for Prisma equity. But each of these guidelines are accompanied by an explanation and elaboration document, which includes quite long slabs of text, really, which essentially provide rationale for why to report something, what's the evidence about why it's important to report something, but they also include, like, for example, down the bottom here in green, actual actionable recommendations telling people to report something in addition to what appears in the blue checklist item. So we extracted all that information from these guidelines, and then 2 authors independently compared these recommendations across all the guidelines and coded them as being either identical in meaning, addressing the same concept of important differences, or unique to the guideline. And then we drafted proposals for what to do with each recommendation, either include it in the unified statement, remove it because it was redundant, or to harmonize wording across similarly worded recommendations. And then we shared all our proposals and extractions with the extension teams, seeking clarification that we hadn't missed any recommendations that should have been extracted or inappropriately included things that were never meant to be a recommendation, and sought their feedback on the proposals. And gave them these harmonization forms, we call them, for them to provide comment on our work, essentially, and having them involved in our harmonization process. So in terms of results, we included 13 of the Prisma extensions that exist for systematic reviews of interventions, along with Tidier for systematic reviews and the SWIM guideline, which are heavily aligned with Prisma. I just want to acknowledge the contributors. These are all the people who commented on all the harmonization reports and gave us input into the wording for all this material. Now, scary side, across the 13 recommendations, we essentially extracted 453 items and 848 elements. Once harmonized, this is reduced down to 50 unique items, but still 465 unique elements. Consider this, though, as an item bank. The only time you would ever be expected to adhere to all these things is, for example, you were doing a systematic review with a living systematic review, I should say, with network meta-analysis of individual patient data, evaluating both the efficacy and the harms of complex interventions, simple interventions, and also focus on equity issues as well. I don't think all reviews will do that. Many reviews will do that. So most of these proposals also underwent 2 or 3 revisions based on the feedback received. And just an example of what the unified statement would look like is that here we have, for just the objectives item, we have some elements underneath in the main Prisma 2020 asking you to essentially define your objective and then indicate what you're going to compare in this review. If you then added Prisma IPD, you'd have to add an additional recommendation to conclude some hypotheses relating to participant level subgroups. And then if this was also a living review, you'd need to maybe justify and describe any changes since the preceding version of the review. So ideally, we hope that having done this work, that it will ensure users won't have to sift through redundant or conflicting recommendations when multiple extensions apply. But what we've come to realize through this process is that the more extensions that apply, the more recommendations users need to follow. There hasn't really been a goal to, when these extensions have been developed, there's always, and even I'm guilty of this myself, when we updated Prisma, there's always a desire to add more. And I think even David provided a suggestion too about Prisma IPD might needing to add more guidance about missing data for that particular extension. But I think we now need to come together as the Prisma family and really discuss what are the most essential things so that we don't overwhelm users with all this mountain of guidance and recommendations to follow. And then as an additional step after this, we're creating some web applications that will essentially enable people to create customized Prisma checklists where they can answer some questions about their review. Does it include NMA? Does it include IPD? And it will generate these customized checklists for them. And we're going to do a randomized trial with authors to see if this actually helps improve their reporting or if they actually hate it. So we'll see what they say. That's it. Thank you.
Thanks so much, Matt, for doing that work. It's good that we don't have to sift through all these things ourselves. Any questions?
Great talk, Matt. In general, when you're making a new Prisma extension, do you expect then these authors to reproduce what's in the item bank already? Or would they be proposing just extension modules or something like that?
I mean, I think for now, when we're sort of approving new extensions, we're saying from the start here, this will be the unified statement that you work as your base from, and then you can either add things or tweak things as need be. But we're essentially going to be giving them that unified harmonized checklist for them to work off, rather than going on their own again and then us having to fix it up later.
I guess I got lucky. I'm curious if I have this sense that when there are more guidelines or more like methodological recommendations, that it creates this wild, wild west reality where there's not really anything you have to do because there's so many different things out there you could do. Was this motivated by that concern in practice that like people don't actually adhere to the guidelines because there are so many different guidelines? Or could you talk a little bit about having so many different guidelines has kind of backfired with transparency and reporting?
Yeah, I mean, I think the rationale for it actually came about because of a concern that people weren't using the extensions. So when Prisma 2020 came out, I would hear lots of people just saying, oh, great, we don't need to use Prisma IPD anymore. We don't need to use NMA anymore because there's a new Prisma. So I'm getting a lot of citations from Prisma 2020, which is great for me, but it's not great for all the extension teams who've done all this great work. And I think people are just ignoring that information. So in terms of the Wild West, I'm not sure. Like, I think the way that it's all come about, it's really just been based on if people are interested in doing an extension, they've just gone ahead and done it, often with the participation of David Moore, the lead author. But we've now created a Prisma exec who now has criteria for approving extensions and engages with extension teams to work with them to say, do you actually need this? And how can we work together to sort of make it all fit nicely together? So.
Hi, yeah, really, really interesting talk. Paulina Steklik from Griffith University. I live in the land of evidence-based practice and getting the end users of research. In my world, it's clinicians. And one of the things I think, obviously, it's really important to have reporting guidelines and add more things and transparency and all those things. But what I've noticed over the years, by adding so many things, the papers have almost become unreadable. And I wondered if that there has to be a balance between ensuring transparency for the right reasons, but I feel like that the critical appraisal and end user has been forgotten in this conversation. So when you're doing this, you're obviously going to do a randomized trial with researchers. Are you thinking of, or I'm suggesting maybe you should think of, when the things are written up, are the end users of those research finding it more readable? And I think that's a really big problem at the moment.
Yeah, definitely. And I think ultimately when people have written these guidelines, and I've written in Prisma as well, we've often just say, we want the information reported or deposited somewhere. We've never been really explicit about which artifact it should appear in, the manuscript, data repository, all that. So I think when we essentially go forward, we need to actually take that into consideration because ultimately we want to do some work to actually interviewing different interest holders to say, what is it that you actually need to help making a decision? Like, you might not need all this detailed information about your risk of bias assessments. Someone will. I think there's still benefit in producing it, putting it somewhere, but it might not need to be in the report. So I think that I don't know if there's going to be a one-size-fits-all approach, but there's definitely, we're definitely a recognition that we need to create products that people are actually going to, and hard to sift through, and that's going to be difficult.
Exactly.
So,
thank you.
Mm-hmm.
I think we have time for one more.
Matt, I know this is for interventions, but would this work for the types of studies I was talking about earlier, the meta research studies to look at bias? Because honestly, whenever I submit those, the journal suggests a different guideline, and it's
yeah, I think so, because that's the problem. That's the issue, that a lot of the meta research studies that do involve some systematic review task, like searching for a sample of studies and screening, I think it could work for it. But I think others are also trying to create a guideline for meta research studies themselves. Whether that's doable, I would find that daunting, because I think they all have different designs. But maybe it could work for some of the types of meta research what we do. But ultimately, I think it depends on what the actual design is. So if you're just doing effectively a cross-sectional study of a set of published articles, then technically something like STROBE should work for that rather than Prisma. But then again, strobe is maybe 20 years out of date, so I don't know.
And it could be based on a systematic review.
Exactly. Yeah.
Thanks.
Right, thanks so much. Looking forward to seeing customized version of the checklist. Okay, next up we have Phoebe Nguyen presenting on reproducibility of meta-analytic results in systematic reviews. Let's see if we can get that.
Test. Thank you, Kylie. Just like to acknowledge my team from the Methods and Evidence Synthesis Unit at Monash University, and also thanks to AIMOS for supporting my travel to the conference to present these results to you. So this is a result, a study trying to reproduce meta-analysis. So just gonna make sure. I'm gonna skip that. So to start with, I was told I'm a bit heavy on food analogy, so I try to keep it short. I like to use analogy when trying to explain reproducibility in the context of our study, in that, when you're given, it's like trying to cook a dish in MasterChef. When you are given the exact recipe, you're giving the ingredients that they want for the dish, and the entire kitchen set up to, carry out all the steps of the cooking. And given all that, if you are able to conduct the meta-analysis, reproduce it, and obtain the same or reasonably similar results, then we can say that the meta-analysis is reproducible. That's the gist of the concept. So it's a bit different from replicability, where you have a bit of leeway in how you want to obtain the data or carry out the analysis. So why is it important? We all know meta-analysis, and as part of the systematic review, is a very crucial type of evidence to inform health policies and clinical guidelines. So when a meta-analysis can be reproduced, it means that the users, the readers, or the policy makers, they can interpret and understand the meta-analysis results, and they can also independently verify that, audit the results. And that increases the trust in the validity of the systematic review and the meta-analysis. And more importantly, and I'll revisit this point later, is that if the methods and the data is available to reproduce it, it really helps other researchers to update the meta-analysis when the evidence base has changed or new evidence emerge. So in this study, we are looking to see how reproducible are these meta-analysis when we try to do it for a sample of intervention systematic reviews. And just a caveat, systematic review is a very multi-step process, and this study is sort of focused on just the meta-analysis itself. My colleagues done another study looking at the other steps in the review study. So in the spirit of reproducibility, I'll go a bit in depth into the methods of our study. We start with about 300 reviews that we have from the previous studies. So we try to keep it as representative as possible. So try to get the data, studies from different database, different types of intervention. It was indexed in 2020. And we excluded some meta-analysis, including those that are done using review managers. And then we end up with 121 meta-analysis that we attempted to reproduce. So the question is, why did we exclude the ones from review manager? And the simple question is, typically the forest plot generated from the software has all the data you need and all the information about the methods. So we assume that if we attempt to reproduce it, most of the time we will obtain the same result. So there's not really a need to do that. So with this 121 meta-analysis, we first approach original reviewers by emails, trying to request for any data or code that they use in the conduct of that meta-analysis. If they didn't reply, we will go into the study itself, the supplementary file, any data sharing links that they have, try to get all the data and the code we need to reproduce. So what kind of data we need? Typically, we want to have the summary statistics, the mean or the odds ratios, or the events number for each study. If that's not available, we try to get the individual study effect estimates. We try to get all these statistical methods information so that we can carry out the meta-analysis as faithfully as possible. And whenever any of this information is not available, we sort of have framework to follow. And the gist of it is that we try to assume if this is not specified by the author, what is most likely the default setting of the software? What's the most likely method that they used? And of course, information about software and their versions. Very important for data in R. And of course, we try to get the original code. If it's not available, we have templates that specify all the statistical methods in details, and then we will use it for reproduction. So on the interesting part, for each review, we reproduce the index meta-analysis, which basically means the first one mentioned in the paper. We have me and another colleague. We carry out the reproduction independently, and we compare our results. We adjust it until our results are in alignment. And then we evaluate what we found. We will classify a meta-analysis as fully reproducible if we were able to reproduce it and we get less than 10% discrepancy in the summary estimates and the 95% confidence width. If we got more than 10% discrepancy in either of those things, it is not fully reproducible. And then there are also cases where we just can't reproduce it at all for various reasons. Following that, when we found a difference, we will classify it as a meaningful difference if there's a change in the sign of the effect estimate, or when the 95 confidence interval changed from including the null to not including the null. Yeah, not p-value, of course. This just basically means that these are the changes that most likely will affect the author's conclusion about the intervention effect. So what did we find? We have 121 meta-analyses. 20% of about 20% of the author we contacted actually reply back with some useful information for us. And 95% of our meta-analysis has some form of data available. Some of them only had study level effect estimates, which is not ideal, but okay, we can work with that. And only 17% of meta-analysis had the code available. I have to stress that only 2% of them had it publicly available to us. So 86% of them were fully reproducible, and 6% were not fully reproducible, and 8% couldn't be reproduced at all. But good thing is we don't find any meaningful difference in the reproduced meta-analysis. This is a Bland-Hoffman plot just to show that this is an example of the difference in standardized mean difference between the original SMD and the reproduced SMD. Just mean that most of the differences lie between a very small range of effect. So it's not really making much difference. So in summary, 95% of the meta-analysis could be reproduced. We love the results. And when we reproduce it, most of the time is always the same as the original result. But we had some challenges during the reproduction because of the lack of availability of data or code. And because of that, we really had to spend a lot of time on extracting the data from the studies, try to recreate the code to do that. And, it's go back to my original point in that we really love if the authors could make all this data and code available to the public in the first place, so that it just makes it easier for future reproduction efforts. So some fun stuff. So just to illustrate some of the challenges that we found, this is one of the good days when you have very nice tables to extract data from, and then not some good day when, it's all right, we can work with the individual effect estimates, and then you have some days like this, like, and then some days like this, like, there's no way we can do that. So I would say, I think it's, I don't want us to look at it and then say, it's bad news. It's generally what we find is meta-analysis are reported quite well. And the only next step that we want to improve this space is that we need more transparency and open data sharing. so that it makes it more efficient for reproduction and reanalysis. Hopefully we'll see the paper published soon. It's been accepted to BMJ Medicine. Thank you very much for your attention.
Thanks, Phoebe. All our presentations have been very efficient, so we've got plenty of time now for questions.
Hi, thanks. So did I understand correctly that you excluded kind of 200 or 300 meta-analyses that you thought were very likely to be reproduced?
Yes, so we didn't reproduce those meta-analyses.
Software.
The ones that are, so to elaborate more, those are the ones that are, firstly, they reported that they did it in Review Manager.
Yeah.
They had a forest plot that clearly showed that it's from Review Manager.
Yeah.
And there are the full information about summary estimate, summary statistics for each study. All the methods information is there. So we didn't do one.
I think that's really important.
Yep.
Kind of to how you describe your results. I think the actual news is even better.
Yep.
Right? So you kind of have 200 studies which are most likely to be fine, and even of the worst studies, or like the ones where people had most degrees of freedom, it was still 96%. So I would just be careful, or like maybe say that's even better news. I mean, now the paper's already accepted, but.
Yeah, completely agree. I think that's a good caveat to make. It is the results are applicable to the sample studies that are not in the Review Managers. And in a way, it's sort of good news, because when you look at the supposedly worst sample, you still find a relatively arguable but acceptable result. So when you take into consideration the large proportion of Review Managers, forest plot studies, meta-analysis, it's assumption, but we expect that the reproducible percentage will be slightly higher.
Yeah.
And that was actually true when we did a sensitivity analysis, including those studies in our results. We actually find that the reproducibility percentage is higher.
Right,
Thanks for that. Yeah.
Thanks, Phoebe. Lyle Gurran from the University of Melbourne. In the last few years, there's been a couple of papers published that report the results of their attempts to get data from authors who say that their data is available on request. And the suggestion was that they should change that statement in almost every paper to that the data are not available on request. So two separate studies both reported less than 10% recovery of data requesting from people who had stated explicitly that it would be. So your 19% is actually about 3 times what the first paper reported. So it suggests to me you've got a much more compliant set of investigators than would typically be the case in medical research.
Yeah, I'm kind of surprised as well when we're trying to compare it to other information. But I think partly my hypothesis is that for systematic reviews, it's likely easier because it's basically secondary data that's already publicly available. So they could share that. I think with trial, like people who investigate data sharing in trials, a bit more, how will be able to know this? It'll be a bit more tricky because it has to do with confidentiality and all that. Yeah, so I think it's good news. Yeah.
Thanks, Ray Wang, University of Sydney. Great talk. My question is, what's the inter-rater agreement between you and your co-authors when assessing the findings?
Wow, tricky. I have to admit, for transparency, we didn't carry out a agreement statistics to find out what is a agreement when our first attempt of finding each other. But as part of our study process, the goal is for us to discuss any discrepancy and make sure we arrive at the same result of the reproduction, because that means we are adopting a single reproduce methods for that particular study. Yeah, so first try at reproducing, we don't have the statistical agreement. second try needs to be 100%. Yeah.
Yeah, so your reproducibility rates were quite high, way higher than, for example, for primary studies, which are more like 20% or even single digits. How do you explain that discrepancy or that difference?
How about primary studies? You're talking about trials and observational studies or just trials?
Just single studies, basically.
Yeah, I won't pretend I have all the knowledge compared to our trialist colleagues. My guess is two things. One thing is, the first thing I have to caveat is that some of our meta-analysis could be reproducible, but only using the individual effect estimates. We don't have the summary statistics. So my guess is when you actually request for the summary statistics and use that to reproduce, there might be a difference, but we don't know because we didn't have access to that data. And of course, when we are calculating effect estimates like summaries, standardized mean difference, for example, there are different ways to do that. So there will be a source of difference. Why is it better than primary studies? I honestly don't have an answer. Could be reporting guidelines helping with that. Doing thinking here.
Maybe it's because single studies sometimes are really complex, more complex than a meta-analysis, where typically the procedures are pretty well established.
I would say it really depends on what is the type of primary studies you are talking about and how many research freedoms, like researcher freedom, is available in terms of the kind of analysis they can do and how many things they have to report. For systematic reviews, I think part of it is that our sample of systematic reviews, they have firstly fewer researcher freedoms because it whether it's a random or fixed methods, what type of methods to come up with the effect estimate and heterogeneity estimator. So it's probably fewer methods that you can play around with. Yeah. But yeah, I think that's something we can look further into to give you an accurate answer.
Thank you.
Yeah.
This one was next. Yeah.
Great talk. I was just wondering, did you also try to reproduce the heterogeneity estimates? And also, I've done something quite similar, and I found it quite interesting that you found maybe an order of magnitude more than what I found in environmental science.
Yes, indeed, we reproduce the I-square estimate if it's a random effects meta-analysis, and it's not included here because we find that I-square could be interpreted differently. So, but basically, there was some difference in I-square in some studies, but most, if not all of the case from memory, it wasn't big enough to make a meaningful difference. Yeah, but that's quite subjective. What is a meaningful difference in I-square? There's some percentage point difference, but not like 20% different kind of thing. Yeah.
We have an online question. So very interesting talk. Thank you. How do you go about reproducing the analytical code when it's not available?
Okay. Just gonna go back to that framework here. So when I just use the meta-analysis model as I'll use the method of assigning weight to individual study as a case study. So if it's specified, we use it. If the code is available, we see whether the author indicated as part of the code. If it's not available, we say, okay, did they use meta? Did they use R? Which R package did they use? And if it was the code, if we didn't indicate it in the code, what is the default setting of that package? And then we assume that that's what the author used.
Just one more here. Yeah.
Hi, can we go back a few slides so you can tell us how you found an SMD of 15?
Which is it a Bland-Altman plot or?
With the colorful estimate where you're looking at the Bland-Altman plot.
Oh yeah.
Yeah.
There you go.
What's
Yeah.
that? Because that's crazy.
Crazily low, crazily high.
It's an SMD of less than -15. That's.
Okay, it's
I just have to know. I know it's not a good question. I just can't help myself.
Okay, I think did I say as different? It is actually the difference in SMD. So on the y-axis you have so you have the original SMD of the original meta-analysis, the SMD of the reproduced meta-analysis. We find out the difference between the two of them, and we plot that difference against the mean of these two. On the left. Oh. The outlier.
It's like 9 outliers in one bag. I mean, it's fascinating.
I can go back and find that study for you, so you can have a look at it. But I remember.
I'll do that.
Thanks, everyone. I think you'll agree all our speakers were really fantastic. So let's give them another round of